AAA. Okay. What is abdominal aortic aneurysm? By definition, abdominal aortic aneurysm is a permanent localized dilatation of the abdominal aorta, 0.5 times greater than the normal diameter of the artery. That's more than 3 cm. So it is permanent localized dilatation of the abdominal aorta. Now, the epidemiology. In this slide, we will see how common AAA is. Incidence of AAA is estimated between 4 and 8% of the male population aged 65 years or older. Comparatively, it is between 0.5% and 1% in females, so it is more common in males than in females. As estimated, 80 million people aged 60 years old and older are at risk of having AAA in Western Europe, higher in smokers than in non-smokers, 8 to 1, and the risk decreases slowly after smoking. So the most important risk factor in developing AAA is smoking factor. Now, in the US, the incidence of AAA is about 2 to 4% in the adult population. 12th leading cause of death in Western societies. It is a silent killer because there are symptoms that an aneurysm is developing in the abdominal aorta. Diagnosis is late. Rupture of AAA occurs in about 1 to 3% of men aged 65 years old or more. Of ruptured AAA is about 70 to 95%. Serious. Now, do you know that Albert Einstein died from an abdominal aortic aneurysm? A few years after a successful repair. It was the first successful open repair of abdominal aortic aneurysm. Now, what about risk factors of having AAA? As I said in a moment, smoking is very important risk factor in developing. More than 90% of people who develop aortic aneurysm have smoked at some point in their lives. Hypertension, genetic influence, family history, about 20% risk of having AAA. Alpha-1 antitrypsin deficiency, connective tissue disorders such as Marfan syndrome, Ehlers-Danlos syndrome, strongly associated with AAA. Atherosclerosis, of course, infection, trauma, arthritis, and cystic medial necrosis. COPD is also a risk factor of AAA. The most common risk factor is smoking, and second, hypertension. What about the pathophysiology of AAA? Some of the hypotheses in this slide. The most striking changes are seen in tunica and intima. So the changes in the aorta are mostly in the These changes include accumulation of lipids, informed cells, extracellular free cholesterol crystals, calcifications, thrombosis, and ulcerations, and rupture of the layers. Adventitial inflammatory infiltrate is also present. However, the degradation of tunica media by means of proteolytic process seems to be the basic pathophysiological mechanism of AAA development. Some researchers expression of and activity of matrix metalloproteinase in individual AAA. This leads to elimination of elastin, rendering the aortic wall more susceptible to the influence of blood pressure. Other reports have suggested the serine protease B may contribute to aortic aneurysm rupture. So the pathophysiology, as you see, is a bit complicated, and many hypotheses are present for the development of AAA. AAA. We have two types of classifications. Morphological classification according to the shape of the aneurysm. We have true aneurysm, all the layers of the aorta. True aneurysm is either fusiform or saccular aneurysm. Also, we have pseudoaneurysms, wall, not part of wall, not the whole layers of AAA. Second classification, we have size classification. First, we have ectatic or mild dilatation, let's say less than 3 cm in diameter, 3 to 5 cm, or severe, more than 5 or more than 5.5 cm. Now, what about the clinical features of AAA? Asymptomatic. You may diagnose or discover AAA dentally, physical examination or imaging. Many of patients come to our clinic having AAA discovered while they are ultrasound for some reasons, okay, like renal stone or abdominal distension, UTI, and AAA is discovered by having ultrasound examination. So, it's either asymptomatic, as I said, with incidental finding during physical examination or imaging, or symptomatic. Symptomatic, either it is, like to say, the patient is hemodynamically stable, there is no leak, no rupture, but the patient does have symptoms like abdominal pain, back pain, flank pain. This pain may radiate to the thigh, groin, and testicles. This pain may be due to sudden expansion of the aneurysm or compression of adjacent structures. With the AAA is either asymptomatic, and the AAA is discovered accidentally during examination of the abdomen or during having ultrasound, or the patient has symptoms, but he is hemodynamically stable, that say the aneurysm is intact, there is no rupture or leak. Those are abdominal, back pain, and flank pain, as I said before, due to pressure symptom. pressure effect of the aneurysm, or the AAA is ruptured, will have symptoms and signs of a ruptured abdominal aortic aneurysm. It is back pain, hypotension, and abdominal mass. This classic triad is present than 50% of having AAA. Okay, so not every patient with a ruptured AAA will have this classical triad. So, focus on this. Any with symptoms, assume rupture until proven otherwise. Yeah. Any patient with AAA have abdominal pain, back pain, flank pain, with pulsatile abdominal mass, assume rupture until proved otherwise. Okay. But the classical triad of rupture, as I said, is back pain, hypotension, and pulsatile abdominal mass. So, of course, rupture of AAA means bleeding, retroperitoneal or into the abdominal cavity, either intra-abdominal or retroperitoneal. Create a connection between the aorta and the intestine or inferior vena cava. Flank ecchymosis, appearance of ooze, is a sign of retroperitoneal bleeding, and it is also called Great Turner sign. It's not specific for AAA, but with other symptoms give a clue to the rupture. The mortality of AAA rupture is as high as 90%. Very grave complication. 65 to 75% with ruptured AAA will die before they arrive to the hospital. And up to 90% of those patients with ruptured AAA die before they reach the operating room. So imagine how grave this complication is. Again, I want to focus on this note. Any patient with a AAA with symptoms, you should assume rupture until proved otherwise. When you receive in the emergency department a patient with abdominal pain and pulsatile abdominal mass, even if he is hemodynamically stable, until you make sure that there is no rupture. Okay, so when you receive patient with abdominal pain, smoker, hypertensive, old patient, male with abdominal pain or testicular pain with pulsatile abdominal mass, until you make sure by investigation that there is no rupture. Now, other causes of Great Turner sign, let's say, it's a sign of retroperitoneal bleeding, acute pancreatitis, pancreatic hemorrhage, retroperitoneal hemorrhage for another reason, blunt abdominal trauma, of course, and rupture, hemorrhagic ectopic pregnancy, spontaneous bleeding secondary to coagulopathy, congenital or acquired, aortic rupture. These are causes of a Great Turner sign, like to say ecchymosis in the flanks. What about the diagnosis of AAA? First of all, family history. As I said, family history, 20% is present, familial, maybe 20% risk. Second, physical examination. Pulsatile abdominal mass in the epigastric area. In about 25 up to 20% of cases, the aneurysm may be not palpable. Plain abdominal X-ray may show the outline of aneurysm when the walls of the aneurysm are calcified. Abdominal X-ray is useful only when the aneurysm is calcified. It is not enough imaging method for the diagnosis. Second, abdominal ultrasound. It is an extremely sensitive test for all AAA sizes. Non-invasive and cost-effective, accurate tool in the diagnosis and the assessment of the AAA. Most of the patients, in the clinical practice, are diagnosed of having AAA by ultrasound examination. As you see in this picture, this is an abdominal ultrasound showing AAA, and this arrow showing the site of retroperitoneal bleeding or leak from the aneurysm. Other investigations beside the abdominal ultrasound, CT scan with angiography. Give accurate diagnosis, diameter, and will assess for rupture. Or CT scan with contrast, let's say CTA, as shown here, AAA. Another picture of CTA showing the aneurysm and showing a leak to the retroperitoneal area from the aneurysm. Very nice picture of CT angiography of the abdominal aorta showing suprarenal abdominal aortic aneurysm. Sorry, infrarenal abdominal aortic aneurysm. Also, other investigation, MRI and angiography. We may do formal angiography, or we may do abdominal MRI. Now, what about the complications of AAA? As I said, rupture is the gravest and most common complication of AAA. Peripheral embolization. Sometimes thrombus will form inside the aneurysmal sac, and this thrombus will propagate distally, causing distal embolization. Also, aortic thrombosis. As I said, fistula formation when there is leak or rupture. Fistula may form between the aorta and duodenum, or aorta and IVC. What we call aortoduodenal fistula or aortocaval fistula. Local compression, mass effect on the other intra-abdominal structures, and hydronephrosis due to chronic compression on the ureter. Now, what about the differential diagnosis of AAA? The differential diagnosis of AAA, it's a differential diagnosis of any acute abdominal pain, shock, and back pain. Acute abdominal pain, shock, and back pain, you should consider the following in the differential diagnosis. Of course, MI, pancreatitis, perforated viscous, mesenteric ischemia, renal or biliary colic, and lumbosacral disc disease. Okay. You should, any patient with abdominal pain, shock, back pain, we should consider the following. And of course, AAA should be on the top of the list. Now, what about treatment of AAA? As I said before, AAA may be asymptomatic or symptomatic without rupture or ruptured AAA. There is asymptomatic, symptomatic but without rupture, symptomatic with rupture. Now, first category, asymptomatic AAA. First, confirm that the patient is asymptomatic. When you receive a patient with AAA and is discovered accidentally, and the patient is saying that I have no symptoms at all. Okay? When you receive asymptomatic patients with accidental finding of AAA, the maximum diameter by ultrasound, vascular surgeon for follow-up. This table shows the relation between the size of AAA and growth rate per year and annual risk for rupture. As you see here, when the size of AAA is 3 to 3.9, the growth rate per year is about cm, and rupture risk is 0. When the diameter of or size of AAA is between 4 and 4.9, the growth rate is about, and the rupture risk is about 0.5 up to 5%. When the size of the aneurysm is between 5 and 5.9, the growth rate is about 0.43. The rupture risk is between 3 and 15%. When the size between 6 and 6.9, the growth rate is 64, and the rupture risk is about 10 to 20. But when the aneurysm is 7 or more in cm, the risk of having a rupture is up to %. Now, this suggests that aneurysm less than 4 cm, we will call the patient annually for follow-up. But when aneurysm is more than 5 cm and more than 4 cm and less than 5 cm, the patient every 6 months for follow-up. If the aneurysm diameter more than 5 cm or symptomatic or growing by more than 1 cm per year, we should interfere either by endovascular or open surgical intervention. Okay? Now, symptomatic AAA. That to say, patient have symptoms like pulsatile abdominal mass or abdominal or back or flank pain. As I said, any patient with symptomatic AAA assume rupture until proven otherwise. So immediate vascular surgical consultation, cardiac monitoring, insert large bore IV access, give O2, blood investigation, and prepare about 6 units of blood. You should have CT angiography of the abdomen and admit for repair. Ruptured AAA is a top emergency situation. Immediate vascular surgical consultation. you have to transfer the patient immediately to the OR without further diagnosis. Don't waste the time by doing unnecessary investigations, because you may lose the patient. Imaging is contraindicated in an unstable patient. As I said, place immediate IV access, type and cross blood, and don't delay the transfer for the OR. Now, what about the repair of AAA? We have open repair and we have endovascular repair. I have to say, laparotomy. Regarding open repair, general anesthesia, laparotomy, of course, retroperitoneum is inside to expose the AAA. The aorta and iliac vessels should be clamped, and aorta is replaced with prosthetic grafts. Here, you should clamp the aorta below the renal arteries, and you should clamp both, and then we excise the aneurysm, clots and debris, and then we insert artificial grafts inside the aneurysm. The surgical aneurysm, a significant incision in the abdomen, a large laparotomy incision, with 30 to 90 minutes cross clamp, ischemia, of course, up to 4-hour procedure, very lengthy procedure. Open repair is contraindicated in some patients. After open repair of AAA, the patient may have 1 to 2 days intensive care and 5 to 7 days hospitalization, recovery time. Of course, there is a high perioperative morbidity and 5% risk of mortality after open repair. See here, and this large AAA below the renal vessels. Should be done, of course, by a professional vascular surgeon. Not easy job. Now, endovascular repair of AAA, invasive procedure, no need for laparotomy, of course. And what we do in the endovascular repair of AAA, the AAA is excluded from circulation by inserting an intraluminal stent graft. A stent graft is inserted inside the aneurysm, so the aneurysm will be excluded from the circulation. Has lower perioperative morbidity and mortality, of course, right? But may be less durable and require more frequent follow-up than open repair, of course. And the endovascular repair is typically reserved for elderly or high-risk patients. We may use general, regional, or local anesthesia. Femoral artery are exposed. A graft is introduced through the femoral arteries, and the graft is guided into position by fluoroscopy, be deployed inside the aneurysm. This aneurysm is before stent graft. This aneurysm is after inserting a stent graft. As you see, the aneurysm is totally excluded from the circulation. Reminding you again of White-Turner syndrome. Keep it in mind, please. And thank you very much. Do you have a question? شباب